now we're really down in the weeds with what we did when we took the Beacon project. We explained the Beacon project, Wyatt talked about HIT and sort of the challenges there. And so anyway, so now we are to our next speaker, and this sort of continues for 2 days. So Kimberly Mueller, our next speaker, is a healthcare analyst with HealthInsight. Her healthcare experience includes data collection, validation, and analysis in support of various quality improvement projects, providing research and analytical support for state and national healthcare scorecards, and collaborating on case studies of high-performing healthcare organizations. She coordinates quality improvement efforts in federally, sorry, she did. She did coordinate quality improvement efforts in federally qualified health centers, and she has over 10 years of clinical practice as a medical social worker. She's a licensed clinical social worker in the state of Utah, earned her BS in psychology from Texas Christian University, and her master's in social administration from Case Western Reserve University, plus a master's in public health from the University of Utah. Kimberly.
Okay, thank you. So as Heidi said, I'm a data analyst. I'm not an IT person, but a lot of what I'm going to be talking about today probably has some echoes of health IT, which you've probably heard a lot about today if you've been part of the sort of program of Beacon that's been presented today. So health IT really becomes sort of the driver for what we were looking at in Beacon with respect to data. And so from that perspective, please don't ask me any in-depth IT questions because I won't be able to answer them. So here are the objectives for the discussion that we're going to have today. Just, basically want to kind of give you a little bit of a past and current history of the healthcare of environment data in Utah with an emphasis on the Beacon data, and then understand the potential for healthcare data information to transform how healthcare is delivered, and that includes your healthcare as well. So I was going to do these polls, these electronic polls that use your cell phone, but there's so few of us, we could just raise our hands if that's okay. There's no need to get high-tech about things because, high-tech is great, but it doesn't have to be the be-all, end-all. But I was just curious to know, how many of you see a doctor in an outpatient setting who has an electronic health record? And let's just raise our hands if your answer is yes. Yay, okay, so that's the majority of folks here. And so when it comes to that, we won't ask the no or the not sure because obviously we're mostly yeses. So how important to you is an electronic health record as part of your health management? If your answer is very, raise your hand. If your answer is somewhat, raise your hand. And if your answer is not at all, raise your hand. Okay, great. Well, so I'm kind of preaching to the choir here, but that's okay. So I'm going to skip over the text polling questions because we have decided we're going to skip that. That's going to load, so this is just going to take a second. Sorry. Okay, so moving on to what is HealthInsight? Who are HealthInsight people? And if you've been present for the discussions today, you've probably already heard this, but just in case it was way early in the day and you've forgotten already, or in case you're coming into this late, HealthInsight, we're a private nonprofit community-based organization dedicated to improving health and healthcare in our communities. We're composed of 3 locally governed organizations in Nevada, New Mexico, and Utah. And we really focus on the drivers of quality improvement, patient engagement, and health information technology in our pursuit of improving health and healthcare in our communities. And these are just a couple of examples of the types of contracts and activities that we are participating in across our various states. The discussion today focuses on challenges with data and information to support change, which is sort of what this whole sort of Beacon track has been around, the Beacon Community Program in Utah, and our efforts to improve healthcare in the Salt Lake area. So what is a conundrum? The Beacon Data Conundrum. So data are raw, unorganized facts that need to be processed. And data can be something simple and seemingly random and useless unless it's organized. And once data is processed and organized and structured and presented in a given context, then it becomes useful and then it can become information. Data and information help drive desirable behavior. Many different industries have taken data from different sources and managed to pull it together to make amazing customer experiences. Retail industries do this all the time, where they might take historical information about products that are purchased together and then design display strategies around that. Also using predictive analytics to identify what consumers identifying what consumers have purchased in the past and then using predictive analytics to identify what they might purchase in the future, and then designing targeted email strategies, marketing strategies around those. Nonprofit organizations that have limited funds that need to do fundraising campaigns also leverage predictive analytics to be able to target the limited resources they have to individuals that are going to be the most likely to donate to a particular cause. Of course, search engines. Search engines look at your previous search histories and preferences that you've recorded, and they can help design and return advertisements to you that are tailored to your particular situation and to your needs. But healthcare is somewhat lagging behind in this trend. And it's not because there's a lack of data, because there's a ton of data, but it's more often a lack of actionable information. So healthcare providers, especially physicians, are very data-driven, and data helps to drive behavior in desirable ways, but it needs to be delivered at the right time and in the right parsimonious fashion so that it augments care, not disrupts care. For those who are already on board with health information technology, information helps to guide treatment decisions and helps ensure that you're offered the appropriate preventive services and that you avoid adverse events like interactions between your medications. And we've seen, you know, obviously in this room, not too many folks are seeing folks that have paper charts. And I heard Wyatt in his previous presentation saying that we're, you know, maybe somewhere up in the 90s for primary care practice anyway in Utah for folks that are using electronic health information, so that's great. We're a leader in that area. So we're swimming in healthcare data, but how can we make sense of it all? We need to go from data management to data leadership, which is a critical transformation. I had to throw a buzzword in there, big data. Woohoo, everybody talks about big data. So what exactly is big data? So big data is a term for massive amounts of information that can be interpreted by analytics to identify trends or patterns in the data. Different organizations leverage big data by gathering records and information and then interpreting it with analytics. And as I said earlier, there are a number of industries that are really sort of out in front using this and have been doing this for a long time. It's less so in healthcare, although there are pockets. For example, Intermountain Healthcare, I think, is a leader in this particular area. And when you have an organization like Intermountain where you have a health plan, you have hospitals, you have providers, you have ancillary services, you've got a lot of information that you can analyze to be able to guide behaviors and guide business intelligence. Some hospital systems who are just a lone hospital system have been able to do this well, for example, with unplanned readmissions. So they've looked at their data to identify who are the patients that are coming back within 30 days to the hospital and what are the risk factors associated with those individuals, and then they're using that to be able to tailor interventions when folks come in the hospital the first time to try to keep them from coming back unnecessarily. Many people do believe that big data can be used to help target early warning signs and help improve patient safety, both from a public health perspective and from an individual care perspective. So I have some definitions here. It sounds to me like Wyatt may have covered a lot of this already with you, so I will keep my definition remarks brief in this particular area. Part of what we needed to do in Beacon was to turn data into information, and all of these areas for the most part had a role in it, not so much PHR, but it was so much more of a challenge than we ever anticipated. So health information exchange. So health information exchange provides the capacity to electronically move information, most often clinical information, what we would call a clinical health information exchange or a cHIE, but also administrative information, while maintaining the meaning of the data being exchanged. And the goal of the HIE is to facilitate access and retrieval, again, of clinical data when you're talking about a cHIE, to provide safer and more timely, efficient, effective, equitable, patient-centered care. Also useful to public health authorities to assist in the analysis of the health of a population. An electronic health record, or an EHR, an evolving concept, but systematic collection of health information in a digital format capable of being shared across different networks, theoretically, includes a range of data, including demographics, diagnoses, test results, medications, immunization history, et cetera, et cetera. A personal health record is a record where data and information related to the care of a patient is stored, but it sort of stands in contrast to electronic health record because a PHR is more often managed and maintained by the patient, whereas an electronic health record is more often managed by the provider of care, so the hospital or the physician office. So with an EHR, the people who are putting data into it tend to be the doctors or the nurses or the billing staff of the facility of care, whereas a PHR, the information is generally going in from the patient. They're putting their own data into their PHR, and that might be something that is cloud-based, like Health Vault, or it could even be something that's kept on a thumb drive that I theoretically could take with me to my doctor's appointments and be able to share with him or her so that they could see my whole medical history. ONC, I know that Wyatt did talk about that, the Office of the National Coordinator for Healthcare, really the principal federal entity charged with the coordination of nationwide efforts to implement and use the most advanced health information technology and guide the electronic exchange of information and meaningful use. I know that he discussed that as well. The set of standards defined by incentive programs that governs the use of electronic health records and enables eligible providers and hospitals to earn incentive payments by meeting specific criteria around meaningful use. But the main goal is to promote the spread of electronic health records and improve the provision of health care in the United States because they tend to provide more complete and accurate information, provide better access to information, and also empower patients to get involved in their care. And I'll speak a little bit more about that later. APCD stands for All Payer Claims Database, and All Payer Claims Databases combine data from different payers in a state, giving policymakers and others information on costs and quality and utilization, barriers to care, patterns of where care is accessed. And when the data are made publicly available, it also enables consumers and purchasers to be able to make decisions, healthcare decisions, based upon things like price and quality, which is sometimes very hard to come by. APCDs are very powerful tools in the states where they're used, and currently there are about 10 states in the U.S. that have APCDs that are up and running, including Utah. There are about 28 states that are in various stages of bringing them online, and only about 12 where there's really no substantial activity in bringing all payer claims databases up. And as you might have heard from earlier presentations today from Mark Bennett and from Christy North, when you're talking about healthcare payment reform and moving into things like accountable care organizations or bundled payments or episode of care payments, all payer claims databases are really critical towards making those kinds of health reforms possible because it aids in the analysis of that kind of data, providing information on diagnoses, procedures, providers, costs, that kind of thing. So data are contained in various places, in EHRs at the site of where care is provided, perhaps in PHRs that I own, that's a standalone service, maybe at the health plan that I use. They've got my billing data that's in there. And so if those silos are just sort of isolated from one another, then that's not an effective use of that information, and we're not leveraging the opportunities that we have to be able to use that information to drive better care. Interoperability is needed to bring the silos together, but unfortunately, different systems don't always speak the same language, and even different EHRs don't even speak the same language. And then, of course, privacy and security concerns are always paramount, and we've had 2 episodes in Utah in the last couple of years where there have been breaches of data. One was more low-tech in terms of a list that was generated, that was distributed, but last year there was an actual breach of a database where numerous individuals' private information was compromised, and some estimates have the cost of that breach up somewhere near $400 to $500 million when all is said and done. Cost mostly borne by, unfortunately, banks and retailers for unauthorized charges and things for individuals who were had their identities compromised. But the thing about electronic health records, I mean, there's trade-offs with everything. With an electronic health record, there's an auditing function, so you can see, anybody can see who has accessed an electronic health record. With a paper chart, you have no idea who's accessed it, you have no idea who's made copies of it. On the other hand, you don't really have people breaking into doctors' offices and making up with a bunch of paper charts either. So having a database makes a pretty tempting repository for individuals who are bent on nefarious purposes. So again, there's kind of pros and cons to each of those. But in most cases, I would say, breaches of privacy and security are rare. By and large, the majority of health information that is protected appropriately and safely and securely, and that's why you don't hear about these breaches all that often. So using this background as context, I'm going to dial down to the specific situation that we had with Beacon in terms of trying to identify and obtain actionable data to improve healthcare quality, efficiency, and cost. So funded by the ONC, The Beacon Community Cooperative Agreement Program demonstrates how building health information technology infrastructure and the meaningful use of electronic health records can advance the vision of patient-centered care while achieving the three-part aim of better health, better care, and lower cost or better value. The ONC has provided $250 million over 3 years to 17 communities across the United States that have already made inroads in the development of secure, private, and accurate systems of electronic health record adoption and health information exchange. So in Utah, the Beacon covered several different partners and efforts, but the main focus for HealthInsight was on improving diabetes care, or care for people with diabetes who were seen in the Salt Lake Metropolitan Statistical Area, which is Tooele County, Summit County, and Salt Lake County, seen at providers that were already, had already implemented an electronic health record and joined on in our collaborative program. So the idea is that improving diabetes primary care, representing about 25,000 individuals with diabetes in the Salt Lake MSA, would improved management would lead to fewer complications like unnecessary emergency department visits and unnecessary hospitalizations. And improved management was measured by using standardized, nationally endorsed quality measures that are a reflection of evidence-based care, like whether or not the folks with diabetes had had their A1C test tested on a regular basis, they had their cholesterol tested on a regular basis, and then were those values in control. So as part of meaningful use, EHRs went through a certification process that, among other things, enables reporting on certain quality measures. But each of the Beacon clinics ended up, they all had different electronic health records. They're all independent of us, and they all selected their vendors independent of us. So there were multiple different vendors that we were looking at, and not all electronic health records have the same quality measures programmed in them. And those that do have quality measures programmed into them, there's different levels of fidelity to the actual national standards of the measures. I'm going to skip ahead here to sort of this is a low-tech version. This is certainly not any kind of a schematic version of the optimal state of how health IT would help inform our data gathering process. So in the ideal world, you'd go to see your provider and he would have his electronic health record, or she would have her electronic health record. There'd be a two-way interface between that electronic health record and the cHIE. Oh, I got a little thing here, there we go. That would enable the sharing of information back and forth to support clinical care, and this is all with the assumption of appropriate permissions having been granted by the patient. I didn't put that in there because that's sort of an assumption of everything, but I do want to make sure that I clarify that. You know, the provider's office might have their own lab that they work with, or an internal lab, and so there's an interface between the lab to the electronic health record so the results are getting in. Perhaps I've been in the hospital recently and they ran a bunch of tests, and so if those hospitals and their labs are all connected to the cHIE, then theoretically when I go in and see my provider, all my data are going to be there, and it's going to be a comprehensive picture of my care, and the physician is going to be able to react and respond to that full picture in an appropriate manner, and it'll save his time and my time and our time and decrease waste. And a secondary benefit of having a clinical health information exchange for secondary uses is performance feedback with benchmarks, so that theoretically the provider or the clinic that I see can get some periodic feedback reports from the cHIE that would let them know how they're doing in terms of their performance quality relative to their peers and others in the community. That doesn't exist yet, but again, this is sort of the optimal state, ideal, what we'd like to see at some point. Well, the reality is it wasn't quite that easy. So some of the issues that complicate the processes that we ran into with Health IT is, for example, free text versus structured fields. So in many electronic health records, there are particular structured fields where data belongs about a specific question so that it can be queried in a standardized fashion on a regular basis, and you can get some consistent, reliable results. Unfortunately, not all EHRs have all relevant fields programmed. So as an example, with the Beacon project, we were looking at the care of patients with diabetes, and one of the quality measures is foot exams, regular foot exams. Folks with diabetes should have regular foot exams. And some EHRs have a place to record that information in a structured, queryable field, and some do not. And so if there's not one in there, then it's recorded in a free text, kind of the way clinical notes used to be taken from providers. But anything that's in a free text field is very unlikely to be able to be queried by an electronic health record. They're usually only able to query structured fields. So data that's kept in a free text field, it's very difficult to get anything back out of that. So you could query the EHR and say, how many patients of Dr. X with diabetes have had a foot exam in the last year? And if that data is contained, some in free text, some in structured fields, you're not going to get an accurate picture of what's going on in that practice. Workflow issues is another one, and that's related to free text and structured fields, because we found that in many cases, providers, even within the same office, using the same EHR, documented information differently. And when information is documented differently, it's very difficult to get it out in a structured fashion. Interfaces. I think I heard Wyatt talking about this. It's very difficult to get the interfaces built between the electronic health record and the cHIE, because you have to kind of get the vendor to work with the EHR and the cHIE, and as Wyatt was saying, they're working with multiple health information exchanges around the country, and we're just one in a series of people crying out for their help. And opt-in, opt-out, Wyatt, I heard him talk about that as well. That's an issue that has slowed down a little bit of the process, because instead of the information being in there, I have to specifically request it to be in there before my provider can, under an authorized circumstance, request to get it back out. And it's very difficult to roll up data across providers for quality measurement, particularly when they operate in the same office. Because when you look to identify patients and services that might be numerator or denominator, and then patients and services might cross different providers, you roll that up, you have the risk of having duplication, and that makes it very, very difficult.
On the opt-in, opt-out, is it once done, it's for everybody, all the doctors and hospitals and everything in the state? Or do you have to do it for each individual location?
My understanding is that once you're in, and then when you go to a particular provider, they need to work a process with you of getting the permission in order to access, because they can't just go in and look at it. They have to attest when they, like, let's say you've said that your data are going to be in the cHIE, and then you go to a hospital. Before that hospital can access your records, they have to attest that you are a patient there and that you have, given them the agreement that they can go in and look at your data. But don't hold me to that, because I'm not a consent expert. But that's my understanding of it there. So the thing that I think is sort of interesting about this particular process here too is that just 2 weeks ago, Farzad Mostashari, the head of the ONC, was giving a national speech, and he said this thing, and I just think it's amazing because it's just so relevant, unfortunately. Quote, "We're about halfway through the process of computerizing and digitizing America's hospitals and doctors' offices, and we're about 5% of the way through changing workflows and redesigning care to take advantage of those technologies." And unfortunately, I think that we encountered a lot of that struggle in Beacon, just because we had some great ideas about how things were going to work, but once we actually got in there, it was a little bit more difficult than that. So I'm going to go back over here now to the APCD. We were going to go to the APCD to get data for the administrative data that we needed for Beacon to evaluate emergency department visits, reductions in emergency department visits, and hospitalizations. The all-payer database in Utah was developed through a series of legislative actions starting in about 2007, and it currently receives about 65 million claims annually. But last year, their analytics vendor went out of business, and so right now we have a great big database, and the wells are still filling, but there's no way to really operate on, analyze the data that's in there, and get anything useful out of it in a systematic fashion. So earlier this year, they issued an RFP, and they're wrapping up that process now, and hope to have a new analytics vendor by summertime. And so once that new vendor gets implemented and is off and running, then we'll be able to get meaningful information out of our all-payer claims database again. But that is going to take a little bit of time, unfortunately. So what did we do to solve our various conundrum? So of course our plan A, when we first got the Beacon agreement, was, oh, well, we'll go to the electronic health records and we'll get the data out of the electronic health records. Well, no, that didn't work, because we found that our measures weren't programmed in, or they weren't programmed in well. So then we thought, well, let's work with the vendors to get the EHRs connected to the cHIE, and then we'll get the data out of a central repository in the cHIE. Well, getting the interfaces built has been a Herculean task, and so that hasn't really worked out either. So we had to move on to plan C. And you know, opportunity brings opportunity. And so we saw a gap in that we needed data. We needed to be able to return actionable data to the providers. And so HealthInsight staff developed an application, a homegrown application that we use that queries the back-end databases of electronic health records after they've been appropriately mapped with the appropriate permissions from the clinics themselves to be able to query the specific fields that we need in order to generate standardized, reliable quality measures that can be compared across providers for purposes of assessing performance and then improving performance. Feedback is critical to improvement, and we were able to generate reports that we would give to providers to help them see how they were doing on the particular quality measures and then how they were doing relative to the other community benchmarks, the community average, for example. So providers being incredibly competitive and data-driven, if we had a group that saw that perhaps their performance was 10 or 20 percentage points below the community average, it was very motivating for them to be able to decide, hey, we need to do something about this. We need to bring our patients back in. We need to make sure that we're getting the appropriate tests and preventive care for all of our patients because we don't want to be laggards. So it really was, it was quite motivating, and having this ability to bring the data together enabled us to do that. And health system partners that participated with us in Beacon who had their own systems were willing to contribute data to us as well. So we had a pretty rich data set that we were able to work with. We're still working to get data in the cHIE. Again, the interfaces take a long time, and consent kind of slows things down a little bit too, but slowly but surely that seems to be coming online. So what did we accomplish so far? Change is hard. Always change is hard. And it took work with a lot of numerous partners developing community buy-in, and we're not done, but we're certainly in a better position than we were when we started. And by integrating various solutions to known and emerging challenges and barriers and limitations, we were able to provide actionable information to providers to help them gauge their performance and improve the care they give to their patients with diabetes and with others, because the lessons that are learned with a condition of focus like diabetes are transferable across other conditions, so they can be applied to folks with asthma, COPD, heart failure. It doesn't end just with diabetes. We've been able to track our progress at the community level and help lift all boats by engaging clinics with one another. So when we've had some high-performing clinics, we've been able to engage them with clinics that are struggling so that they can share their successes and share their workflows and help improve others in the community as well. And because of all of this, we can say that the measurement system in our community is definitely stronger than when we started, and we have impacted the care of about 25,000 individuals with diabetes in the Salt Lake metropolitan statistical area, and that is no small feat, and we're pretty proud of that, I have to say. So lessons learned. We are still harvesting these. We have about 4 more months in the Beacon contract, and I think the main lesson that we've learned from the data perspective is that, you know, this is sort of my metaphor. The house is a metaphor for, you know, having an ideal, maybe this isn't great, but it's the best picture I could find. So having a great measurement structure, infrastructure, data and information infrastructure, but if you don't have the supporting processes working together and strong and coordinated, then you end up with a house that is going to fall over when the first big wave comes or the first big wind comes, because the support is not there. It's not coordinated, it's not working together, and it's not particularly strong. So you can dream about the greatest house in the world, but if you don't work on getting the foundation in place and strengthened first, then your house is probably going to get blown over, and then you'll be homeless, and that's not good. So where do we go from here? So as healthcare records move to electronic systems, the data that are routinely collected as part of medical care, they hold the promise for dramatically increasing the opportunities for learning and improving care on a national scale. Turning data into the data that's collected at the time of care into knowledge can be used in clinical practice, and it's essential if we're going to achieve a learning healthcare system or a system that continuously and seamlessly uses healthcare data from across various providers to answer important questions that matter both to patients and to clinicians. So what does this mean to each of us? And you know, I think I'm preaching, as I said earlier, to the choir here, because we probably all have experienced this. if we're engaged with an information-driven provider. But the test results are available when we go in to see the doctor. I don't have to go get a duplicate copy of the test and pay for it, and my health plan doesn't have to pay for it, because the test that I had done across town is in the cHIE, and my doctor can pull up those results and see it while I'm sitting in front of him. We can talk about it immediately. And therefore, my medication can be adjusted immediately based upon the results and evidence, and I can get my condition in control that much faster. It can help avoid adverse events like potential drug-drug interactions. If my provider wants to prescribe something new for me and it interacts in a negative way with the medication that I'm currently on, the electronic health record is going to prompt that physician and say, hey, there's a potential interaction. Are you sure you want to do this? And then we can have a discussion together to decide what to do about it. I can receive recommendations on appropriate screenings. My doctor will know if I'm overdue for a mammogram or a pap smear or a colonoscopy or whatever the case might be, and make sure that I get referrals for those at an appropriate time and I don't get overdue too far. I can get, immediately written information about my condition, because electronic health records are able to query my diagnoses, my medications, for example, and generate a packet of information that my provider can print out, in most cases with EHRs, at a touch of a button, that help me understand more about my condition, how to better manage it, and what are some red flags that I might need to look for. And it's nice to be able to follow up and communicate with a provider via a secure email or a portal. And I mean, this really just happened to me. My husband had to go in for sleep study. And so after he had the sleep study, he was able to log into the portal and see the report that was generated, and he was able to email his provider and said, okay, what are we going to do now? And the provider emailed back and said, well, I'm going to make a referral for you to a DME company so you can get a CPAP, and blah, blah, blah. And this was all done electronically, at everybody's convenience, which was great. And so we were able to get the answers that we needed and get going pretty quickly without having to wait a long time for low-tech communication, which is what happens when you have a non-information-driven provider. You might have to have tests duplicated, again, which is money out of my pocket. I might have to wait longer for my condition to be controlled because the test results are not available. I might have to sit in the office waiting for a while they're looking for my chart before I can even get in and see the doctor, and I've experienced that firsthand. Maybe the fax is out of order, so when I went to a specialist that I was referred to by my primary care physician, they didn't have my records because they didn't get my faxed records that were sent, a week or two ago, because the fax wasn't working, or they had the wrong fax number, or whatever the case might be. Or playing phone tag to get the results of tests, because that's something, again, that I personally have experienced, where I go to see the doctor, I have a test, I call the doctor's office, hey, do you have my test results? Oh, he's in with somebody, he'll have to call you back. Okay, fine. And then he calls back while I'm in a meeting, and so I come back, I get a voicemail, I call him back, he's in with another patient, the nurse is not available. It's frustrating. And so having to play that sort of low-tech phone tag is a waste of everybody's time and energy, whereas if you have a portal or a secure email communication system, you can get information and exchange it quickly. And in many cases, without having to go back and see the doctor's going back to the doctor's office, which is the way it's always been like previously, is come back in 2 weeks and we'll talk about your test results. Well, maybe I don't need to come back, and then that saves me money, that saves the doctor's money, and it saves all of us time. So the future, what does the future look like? Clinical data are of little use to anyone if they remain unanalyzed and in silos that are characterized by traditional paper records or unlinked electronic systems. It's in the analysis of the data and the application of those results that the potential to drive continued improvement lies. So the questions that researchers and hospital administrators and public health officials are asking of data are really targeted towards improving the safety and the value of healthcare to help improve the health of individuals and populations. There's potential in the use of routinely collected information to detect and respond to disease outbreaks, to target medical services to those who need them most, and to help patients and clinicians make better decisions and avoid errors that can harm patients. There's a growing awareness of the value of integrated health data, and surveys generally show that patients support provider use of electronic health records, but again, they're very concerned about things like privacy and security. But when there are safeguards to protect identity, 68% of those recently surveyed expressed willingness to allow health information to be used to detect outbreaks, bioterror attacks, and even fraud. And almost 90% of respondents agreed or strongly agreed with the statement my health data should be used to help improve the care of patients who might have the same or similar condition. So clearly there's a lot of support for this on both sides of the fence there. So clinical data collected during the course of care and transformed into information provides the opportunity to learn from experiences and continually improve future efforts towards the triple aim of better care, better health, and better value for our healthcare dollar. So that's it for me. Any follow-up questions? Yes.
Yeah, with your guideline plan A, plan B, et cetera, how did you solve the pretext field problem?
Well, it's a lot of workflow issues. I mean, in some cases, we've worked with vendors who have been able to sort of see if the data is stored in free text in a certain fashion, DM foot exam, that they can query that in some cases. If there is a structured field, we work with the providers to identify where is the structured field and then work with everyone in the clinic to make sure that everybody is putting it in that field in a consistent fashion. If it doesn't exist, it doesn't exist, and there's not a whole lot we can do about it. So in some cases, we had clinics who were concerned enough that they actually went back and did chart reviews, which is just, you know, horrifying to even think that they have to spend the time on it. But they wanted to know what their performance was, and they wanted to know where they were having gaps and where they needed to recall patients or have patients come back in to make sure that they had given them the care that they need to have, evidence-based care.
Did you find that if certain structured fields didn't exist that you needed, the EHR systems were extensible enough they could potentially be added?
I think that probably potentially yes, but you usually have to go through the vendor for those kinds of modifications to be made, and the receptivity to those kinds of customizations, it varies depending upon vendor. And in some cases, customization is really part of their model, and so they've customized themselves into some unique little process over here that makes it very difficult to do anything. And then there's others who are sort of not customizing a whole lot. So there's sort of a variety and a range out there, and we just have to kind of work with what we have. And I think that was something that White had kind of said too, which was it's not perfect data, but it's the best that we have, and we have to work with it, and it's a place to start. And as we keep going and as we keep identifying where there are these gaps, things like we don't have the right fields that we need, or we're not all using the fields in the right way, or we don't understand how to use the fields, then we can get those problems addressed, and little by little the quality of the data will improve so that the quality of the outcomes will improve. Thank you.